Welcome to Migraine. You probably have it. This is David Lee Gordon, MD, Professor of Neurology. This presentation is intended for patients and part of a series of presentations on migraine. This is a DLG Insight production. Innovative neuroscience ideas and thoughts on education. Who will learn something from this presentation? The answer is everyone. You will likely discover new information in this handout if you already know you have migraine, if you don't think you have migraine, if you're not a doctor, or if you are a doctor, because there are many misconceptions about migraine, even among health professionals. Have you ever had more than 2 headaches in your life? Of whatever cause, including headaches that you've called regular, tension, stress, or sinus headaches? If you answered yes, you probably have migraine. Have you ever had more than 2 episodes of lower abdominal pain, perhaps with diarrhea or constipation that you blamed on stress, sensitive or nervous stomach, GI virus, food poisoning, or even irritable bowel syndrome, IBS? If you answered yes, you probably have migraine. Have you ever had episodes of visual floaters or tingling over your face, arm, or leg that came and went for no apparent reason? If you answered yes, you probably have migraine. Have you ever had more than 1 episode of vertigo, where you feel like you or the world are moving or spinning? If you answered yes, you probably have migraine. Have you ever had episodes of chest pain for no apparent reason with normal heart, lung, and esophagus tests? If you answered yes, you probably have migraine. Have you ever had episodes of panic attack when you actually felt no anxiety prior to that panic attack? If you answered yes, you probably have migraine, because migraine does not mean bad headache or even headache at all. The severity of a headache has nothing to do with calling it a migraine. You can have a mild migraine headache, and you can have no headache during a migraine attack. Headache is just one of the many symptoms of migraine. Migraine causes many symptoms, and headache is just the tip of the migraine iceberg. All of these symptoms on this page can occur during a migraine attack, many of them commonly. Starting from the bottom, light, noise, and smell intolerance, common in migraine. Sinus congestion, bloody nose, a red ear or face, common in migraine. Weakness on one side of the body, double vision, or imbalance when walking can occur during a migraine. Nausea or vomiting, motion sickness, vertigo where the world is spinning or moving, common in migraine. Lower abdominal pain, diarrhea, constipation, bloating, and gas, common in migraine. Lightheadedness, even fainting, palpitations with a fast heartbeat, all can occur in migraine. High blood pressure spells, common in migraine. Low blood pressure spells can occur in migraine. And of course, visual floaters and tingling and difficulty speaking are all common in migraine, as well as neck, chest, and groin pain in addition to headache. Migraine is actually a brain disorder, not a pain disorder. Headache is a symptom of pain in the head with many possible causes. Migraine's one of them, but there are many others. Migraine is a medical condition in which patients have temporary abnormal brain function with symptoms all over the body that may or may not include headache. Migraine is by far the most common cause of recurrent temporary headaches, but migraine with no headache is also very common. If you don't believe me, believe Oliver Sacks. Oliver Sacks, who lived between 1933 and 2015, was a famous British neurologist and author who wrote the book Awakenings, later turned into a movie starring Robert De Niro and Robin Williams, and Robin Williams played the role of Oliver Sacks in the movie. In his book, Migraine, Revised and Expanded, published in 1992, Oliver Sacks wrote in his introduction, "Headache is never," and he emphasized and italicized never, "headache is never the sole symptom of migraine, nor indeed is it a necessary feature of migraine attacks. This is an excellent book intended for laypersons and quite educational, though it is fairly heavy reading written at a fairly sophisticated level. During a migraine attack, there are several body changes that commonly occur, one of which is chest pain, which may mimic a heart attack or may be misdiagnosed as a panic attack. Also very common are abdominal symptoms during a migraine attack. One can have nausea, vomiting, or heartburn, and this may be misdiagnosed as virus or food poisoning. You can have lower abdominal pain with diarrhea or constipation that may be misdiagnosed as virus, food poisoning, or gluten intolerance, or may be diagnosed as IBS, which actually is abdominal migraine. Blood pressure changes and pulse changes commonly occur during migraine. Most commonly increased blood pressure, sometimes decreased blood pressure, which results in lightheadedness or even fainting. Palpitations, heart pounding or racing commonly occurs during migraine attacks, and these all may be diagnosed as a so-called dysautonomia, abnormal autonomic nervous system. But guess what? Dysautonomia can occur from migraine. Dysautonomous spells can occur in migraine. So calling it dysautonomia does not exclude the possibility that migraine is causing it. You can also have neurologic symptoms during a migraine attack that mimic a stroke, such as spots or lines in the vision, or tingling on one side of the body, a vertigo, the sense the world is moving or spinning, or weird feelings in the head, or difficulty speaking or understanding speech, or even weakness on one side, confusion or amnesia or other deficits or abnormalities that suggest stroke, which may not be. So who gets migraine? Probably all animals, because in fact, migraine is nature's meteorologist. Barometric pressure decreases at the edge of storms before the bad weather arrives, and barometric pressure drops trigger migraine attacks. Barometric pressure drop changes animal behavior, not coincidentally. Dogs, for example, seek dark, secluded areas and vomit and don't eat, all consistent with migraine. Cats seek a dark, secluded area and paw their face or head, consistent with migraine. And in fact, before there were radios, sailors used to keep cats on the decks of ships and knew a storm was coming when the cats went below deck because they were avoiding the light. They didn't realize that's what they were doing, but that's what they were doing because they had a migraine. Rats and mice, when the barometric pressure drops, exhibit pain-related behavior. In other words, behavior that suggests they're in pain. When the barometric pressure drops, deer decrease their activity, seek secluded area, and all experienced deer hunters know that it's not a good day to go deer hunting when the barometric pressure has decreased. When barometric pressure drops, birds seek nests, avoid flying, and fish and sharks swim to deeper water. All of these behaviors suggest that barometric pressure is affecting animals in some way, and it makes most sense to me to be part of a migrainous phenomenon that animals have just like humans. Among human beings, who gets migraine? Well, everyone, people of all ages and genders. Since you inherit migraine, migraine attacks can occur at any age, from infancy to the elderly. And the likelihood of inheriting the migraine gene is the same for all genders. Most, if not all people, likely have migraine. Due to a combination of genetic and environmental factors, however, some persons have rare, non-bothersome migraine attacks and may not even know they have migraine, while others have frequent bothersome attacks and perhaps do know they have migraine. So if migraine is not a bad headache, what is migraine? Well, it's a genetic tendency to have attacks, a genetic condition, in other words, you get it from your mother or father, in which a person has a tendency to suffer repetitive, temporary spells or attacks. And what is a migraine attack? In essence, a slow motion seizure. Hyperexcitable brain nerves cause both seizures and migraine attacks. Seizures consist of episodes of abnormal electrical activity shooting across the brain in seconds, like a rapid electrical storm. Whereas migraine attacks consist of episodes of abnormal chemical activity marching across the brain more slowly over minutes to hours to days, like a slow chemical chain reaction across the brain. Let's dive a little deeper into what's going on during a migraine attack. In essence, it's about leaky brain cells and associated body symptoms. So first of all, you have a migraine gene that results in having an area of the brain with leaky and excitable brain cells called neurons. Second of all, there are these environmental triggers, for example, weather, stress, or hormone changes that cause the leaky, excitable neurons to turn on and begin an attack. Then there are chemical changes with chain reaction that march across the brain during the attack. And finally, these chemical changes in the brain result in body symptoms and headache. So migraine is a brain problem. Why does it cause body symptoms? Well, it does so because the brain affects your body because it controls nerves to your arteries, and artery changes affect blood pressure and sinus congestion. Sinus congestion, if you didn't know, is due to swollen arteries in the nose and sinuses, not due to snot. In fact, decongestants work by constricting the arteries in your nose. The problem is when it constricts your arteries in your nose, it constricts arteries other places and then results in high blood pressure. So decongestants actually aren't good for you. The brain also affects your body because it controls the nerves to your stomach and intestines. So the brain can cause stomach and abdominal symptoms. And finally, the brain affects your body because it controls your perception of vision, sensation, and movement. So the brain can cause visual symptoms such as spots, dots, lights, or zigzag lines in your vision. It can cause you to have tingling on one side of the body, and it can cause you to have vertigo, a sensation the world is moving or spinning. So by the way, if you'll notice, as I talked about the brain's effect on the arteries, stomach, and intestines, the part of the nervous system that controls the arteries, heart, and gastrointestinal tract is called the autonomic nervous system. Autonomic, or automatic, if you will. The autonomic nervous system control center is in the brain. So brain dysfunction due to migraine may cause dysfunction of the autonomic nervous system, and doctors call this dysautonomia. Migraine is a common yet under-recognized cause of transient dysautonomia spells. So am I saying that everything's a migraine attack? No, I am not. But human beings, and probably animals, have many different types of symptoms throughout their life that are bothersome but not dangerous and get better on their own. Traditionally, doctors and grandmothers have diagnosed these symptoms as being due to many different conditions. However, many of these symptoms are actually consistent with one condition, migraine, and improve with migraine therapies. Once you understand migraine, you will see that migraine attacks have a distinct pattern. After listening to this presentation, hopefully you will have new migraine glasses and the pattern will become clear. Symptoms that seem vague or psychiatric are clearly due to migraine when seen through the proper lenses. If a person, including doctors, don't understand migraine, they don't have their migraine glasses on, then symptoms can seem vague and unrelated, maybe psychiatric, maybe the patient's manipulating me, the doctor might think. A diagnosis without migraine understanding don't make sense. The things don't make sense. The doctor thinks the patient's crazy. Yet when seen through migraine glasses, when you understand what migraine is, now you see the symptoms as being clearly migraine. You diagnose migraine well, a pattern emerges. Here are some important clues that someone is suffering a migraine attack, typical features of migraine attacks. First of all, migraine is genetic, so it is important to know that almost everybody who presents to a doctor will have had previous similar spells. Either they will or their family will have previous similar spells. This is very important. Migraine attacks are genetic. Also, migraine causes temporary symptoms. The symptoms always get better after some time, usually minutes to hours, but occasionally days to weeks. During most migraine attacks, patients will have sensitivity to sensory stimulation. In other words, intolerance to light, noise, movement, or certain smells or heat. The patient wants to lie down still in a dark, quiet, cold room. And nausea or vomiting is very common during migraine attacks, often, even if you don't have true abdominal pain. One of the challenges with teaching about migraine are the many myths about headache that are based on misunderstood relationships. For example, eating certain foods. Sometimes after eating chocolate, nuts, peanut butter, bananas, sweets, or fatty foods, you'll notice you get a headache and think that the food caused the headache. This is not true. I'll explain in a moment. Blood pressure changes. Sometimes you have a headache or feel strange and find your blood pressure is high and think the high blood pressure caused your symptoms. This is not true. And stuffy nose. Sometimes you get a stuffy nose, perhaps with clear drainage that later turns colored, with associated headache or pressure over your forehead and cheeks, and you think you have a sinus infection or allergy. This is not true. Let's clarify these relationships. Chocolate, nuts, and certain other foods actually treat migraine headaches. They do not cause them. During migraine attacks, your brain and body are low in the chemical serotonin. So your brain makes you crave foods that raise your serotonin, such as chocolate, nuts, bananas, sweets, and fatty foods. If you have a headache after eating these foods, you actually didn't have enough of them. High blood pressure does not cause headache. However, migraine causes a temporary rise or sometimes a drop in blood pressure. You cannot actually feel high blood pressure. High blood pressure causes no symptoms, and in fact, the American Heart Association calls high blood pressure the silent killer. If you sense your blood pressure is high, you're actually having a migraine attack. The symptoms you feel are migraine, and just so happens, the migraine attack is causing your pressure to go up. All sinus headaches are actually migraine headaches. During migraine attacks, the pain nerve to the face causes the arteries in the nose to swell, causing sinus congestion. Studies show that antibiotics do not help sinus headaches, but migraine medications do. Now, I'm not saying that all sinus congestion is migraine. I didn't say that. I said all sinus headaches are migraine headaches. Because when you have pressure sensation or pain in the head or cheeks over the forehead, that's a migraine. You can have sinus congestion with runny nose and sneezing and itchy eyes with no pain or no pressure sensation. That's actually due to allergies. So there's different reasons for sinus congestion, but sinus headaches per se are always migraine headaches. So you have the gene for migraine. Why did you get a migraine attack now? It's because there are these things called migraine attack triggers. The migraine brain does not like change, and certain changes in your internal or external environment can bring on or trigger migraine attacks by causing the hyperexcitable leaky brain nerves to fire. There are 5 main categories of migraine triggers: environmental changes, hormonal changes, sleep changes, diet changes, and other physiologic changes. The environmental changes that can trigger a migraine attack include barometric pressure changes, motion, and certain scents or smells. Weather fronts are associated with low barometric pressure on the outskirts. High altitude is associated with low barometric pressure. So if you get migrainous symptoms, whether they be headache or nausea or light bothering your eyes or tummy aches or whatever, when the weather comes through, weather changes come through, it's probably a migraine attack triggered by the low barometric pressure in the weather front. If you get so-called altitude sickness, that is consistent with a migraine. Think it through for a second. What is the altitude sickness? Nausea, don't feel well, headache. That's a migraine triggered by the change in barometric pressure when you go to a higher altitude. Motion sickness is actually a migraine attack. The nausea you feel, the dizziness, the not feeling well, is a migraine triggered by motion. And many colognes or perfumes, smoke from cigarettes or fires, fumes from paint, gas, or cleaners, etc., can trigger migraine attacks. If you ever feel queasy when you smell somebody's perfume, or when you're smelling smoke, for example, or paint, etc., you're having a migraine attack. The hormonal changes that can trigger a migraine attack include adrenaline changes, estrogen changes, testosterone changes, and thyroid hormone changes. So adrenaline changes occur during stress or exercise. The most common time for you to have a migraine attack is during a stress letdown time. In other words, right after stress. If you think about it for a second, so-called tension headaches actually occur at the end of stress, not during stress, at the end of the day when you already have told yourself you're going home soon. As soon as you say that to yourself, you actually relax, and then the headache comes on. You don't get a tension headache because you're scrunching your shoulders or squinting your eyes, or no, it's because you specifically relaxed. So it's a stress letdown migraine. Sometimes migraine attacks can occur during stress itself, but it's also very common for exercise to trigger a migraine attack because of the changes in adrenaline that occur with exercise. For women, estrogen changes commonly trigger migraine attacks. This is why it is thought that women have more migraine, have migraine condition more often than men. They do not. Now, they may have more attacks in their life because women have estrogen changes on a regular basis, and those estrogen changes trigger attacks, so they're more prone to more frequent attacks, but they do not have the gene more often. So just so you know, estrogen excites neurons, while progesterone inhibits neurons. Those are the two women hormones. So migraine attacks are more common during the times of a woman's cycle when estrogen increases or progesterone decreases. Now, these are during ovulation or menstruation. During ovulation, in both those two times, ovulation and menstruation, the estrogen is higher relatively than the progesterone. Also, at the beginning of periods, when someone starts having periods, they start having more of these migraine attacks, right? So it's called menarche. When you are a young adolescent or young girl and you start having your periods, you're going to notice migraines more. You'll think you didn't get your migraines until you were having your periods, but in fact, you had them before. They just didn't recognize them as such, and they became more regular with your periods when you started developing them. It is common for hormonal contraceptives or pills or implanted devices that have estrogen especially to trigger migraine events all of a sudden or change the character of your migraine attacks. And pregnancy, typically the first trimester, is the most common time when migraine's worse. Now guess what? Morning sickness is also worse in the first trimester. And guess what? Morning sickness is actually migraine. It is a form of migraine. That's what's going on. The nausea, the not feeling well, that is a migraine, and that's morning sickness. You also have changes in estrogen in the postpartum period. So it is common for migraines to worsen around the time of the postpartum, just after you've delivered. And then women who are during menopause or perimenopausal will commonly have more migraine attacks because the ovaries, which are slowly but surely becoming less productive of estrogen, at the end, they start having these irregular spurts of estrogen release. And these irregular spurts trigger migraines. And suddenly women who are in their 40s or maybe early 50s will say, what's going on? Why am I suddenly having all these attacks? It's because of the ovaries changes leading to menopause and these estrogen changes that lead to migraine. Testosterone changes can also trigger migraine. It's not unusual for men who receive testosterone to have changes in their migraine character. Now, some women are found to have low testosterone. Even they get testosterone externally, and they can trigger migraines in them. Thyroid hormone changes can trigger migraine attacks. And occasionally, people who have their thyroid hormone dose changed will have a change in their migraine attacks. Other triggers for migraine attacks include sleep changes, diet changes, and certain physiologic changes. So lack of sleep, excessive sleep, or changes in sleep patterns or work shifts can sometimes trigger migraine attacks. Hunger can trigger migraine attacks. Dehydration, certain preservatives, especially MSG, sulfites in salad bars, or nitrites or nitrates in cured meats. Almost all artificial sweeteners can trigger migraine attacks in some people. And alcohol in some people can trigger migraine attacks, although I think more frequently it's red wine per se that does it. Head trauma, post-concussion headaches, and dizziness are actually migraine triggered by the head trauma. And you can have migraine attacks triggered by changes in blood flow to the brain. Sometimes strokes trigger migraines, blockage of arteries, changes in blood flow. And fever, anemia, sleep apnea, and certain other medical conditions can trigger migraine attacks. So when you get headaches or feel other migrainous symptoms, such as nausea or vertigo or whatever, with these phenomena, it's not that the fever is causing it, it's the fever triggering a migraine which is causing it. The anemia is triggering a migraine which is causing it. Sleep apnea is triggering migraine which is causing it, etc., etc. A migraine attack consists of 4 phases. Let's look in some detail into what's happening in the brain during a migraine attack. So first of all, you must have a genetic predisposition. And then second of all, you have a trigger. And when the trigger occurs, first thing, you have a decrease in serotonin in the brain and body. We call this the prodrome. And the decrease in serotonin leads to mood and appetite centers being activated. The changes related to the prodrome then lead to the aura, the second phase, where excitable neurons cause a chemical chain reaction across the brain. This chemical chain reaction leads to pain because chemicals are released during the aura, and these chemical changes in the brain excite the pain nerves to the head, but also the neck, the chest, and groin. So there are pain nerves that line the meninges. The meninges are a sac around the brain and spinal cord. And this main chemical that does this is CGRP. We're going to learn more about CGRP. It's important to know about it. This chemical turns on the pain nerves. And you didn't know about it because some of the new migraine medicines block CGRP. The fourth phase of the migraine attack is the postdrome. The brain recovers gradually from the wave of decreased activity. Now let's take a deeper dive into the symptoms of migraine related to the 4 phases. So again, you must have a genetic predisposition. Then you have a trigger. And these triggers can include, as we've talked about, drop in barometric pressure from weather or altitude, stress changes, estrogen changes, thyroid changes, sleep changes, hunger, dehydration, food preservatives, artificial sweeteners, alcohol, especially red wine, scents, smoke, fumes, head trauma, etc. This leads to the prodrome. And the prodrome, the 2 main symptoms are mood changes and food cravings. The food cravings for things that raise your serotonin, like chocolate, nuts, bananas, sweets, and fatty foods. But also, you may have difficulty concentrating, some neck stiffness, yawning for no reason. I'm not tired, why am I yawning? Or eyelid twitching for some strange reason. Those can all occur in the prodrome. Now, after the prodrome, the aura comes along, and you get symptoms that are mimicking stroke mimics, like the visual symptoms, or tingling and numbness, difficulty speaking, dizziness or vertigo, weakness on one side, confusion or amnesia, nausea, vomiting, reflux type symptoms, abdominal pain, diarrhea, gas, bloating, constipation, blood pressure changes, palpitations with a fast heartbeat, ear ringing, decreased hearing, or strange smells. And this releases that chemical CGRP, which then goes and turns on the pain receptors or in that sac around the brain called the meninges, and you get a headache. Or maybe it's affecting the nerves, not in the head, but the nerves coming out of the meninges going to the neck or the chest or the groin, so you get pain there. And The pain nerve to the face happens to be the same nerve that controls the arteries to the face. So the arteries of the face swell up, and guess what? You get sinus congestion, you get bloody nose, you get a red ear. The bloody nose is more common in children because when those arteries in the nose swell up in a kid, it's more likely to have the leakage of the blood at the time of the congestion. And people misinterpret this, and they go to a doctor who wants to cauterize the nose instead of asking, by the way, is there any other symptom with it, like nausea or headache or whatever? They don't ask that question. They just go and cauterize the nose. And if the arteries in the ear are the ones that will be affected, your ear will get hot and red, for example. During this phase, there's sensitivity to light, noise, commonly, sometimes motion, smells, or temperature. And then after this phase is over, you have the so-called migraine hangover, the postdrome, which is like the migraine hangover, basically. Malaise and fatigue, difficulty concentrating, mood changes, appetite changes, neck stiffness, and scalp tenderness or pain to the touch. I might add, in my opinion, a hangover from drinking alcohol is actually a migraine triggered by dehydration. Alcohol is a diuretic. In other words, it makes you urinate, and so it dehydrates you. This is why people say you have to, in order to avoid a hangover from alcohol, you should drink a lot of non-alcohol beverages in between. Why? Because you're avoiding dehydration. It's dehydration that is the main reason for the hangover because it's triggering a migraine attack. Looking more closely at the migraine aura. The migraine aura is unique. The symptoms of a migraine aura travel and change. Different parts of the brain have different functions. In migraine attacks, a chemical chain reaction travels across different areas of the brain, and thus aura symptoms tend to travel in the body and change from one to another. Unlike stroke, migraine aura symptoms travel from one part of the body, such as from the face to the arm to the leg, and change from one type to another. For example, first with visual symptoms, then tingling symptoms, then abdominal symptoms. That's not the way it is in stroke. If you look at this picture of a brain to the left, I've put symptoms in the areas of the brain where they're controlled. The back of the brain is the visual area. That's the most common place for the migraine aura to start in most people. So you get visual symptoms, but they move because of symptoms, the chemical chain reaction occurs. And it may be that after the chemical chain reaction, if it goes upwards, it may involve the sensation area, and you get tingling or numbness after the visual. If it keeps going, you may get weakness on one side, etc. Or the visual symptoms may occur, and maybe the wave is not going up, but going to the side, and it may cause distortion of your vision, leading to vertigo, or lead to involving your language area and cause speaking difficulty, etc. You literally can see the brain when you're a doctor taking a careful history, and you realize the symptoms of the patient are literally, you can see them tracking into these areas. Please note that an inner part of the brain controls the autonomic nervous system, the abdominal symptoms and blood pressure and pulse changes. So if the wave hits that area, you're going to have things like diarrhea, abdominal pain, blood pressure changes, increase or decrease in fainting, for example, all because the wave hit that area of the brain that controls the autonomic nervous system. Many health professionals, including doctors, have difficulty differentiating stroke symptoms from migraine aura symptoms. One of the most important factors is stroke symptoms do not travel or change. In other words, when a stroke occurs, a patient has visual and sensation and other symptoms all together at the same time. Doesn't start with vision and then go to tingling, for example, first of all. And this can only be obtained by a careful history, meaning the story the patient tells. If the doctor simply makes his or her assumption based on looking at the patient and not asking how the symptoms started and progressed, he or she may be very uncomfortable diagnosing this as an aura of migraine instead of a stroke. Not only that, there are certain symptoms that are classic or typical for migraine aura and not stroke. So the most classic are migraine visual auras and migraine sensory auras. So migraine visual auras, the shape, they're spots, dots, swirls, lines, wavy or zigzag, or holes in the vision. That's migraine. That's not going to be stroke. The most common color of these visual phenomena are gray, silver, or clear, but they can actually also be multicolored, black, white, even a kaleidoscope of colors. Flashing lights or shimmering quality, very common in migraine auras. And the symptoms tend to move. The dots, spots, lines, etc. tend to move or pulsate or vibrate in the vision. Those are classic migraine visual auras that are not going to be occurring in a stroke. Migraine sensory auras typically are tingling more often than lack of sensation. So instead of you can't feel, it's more like you feel pins and needles or a prickly sensation that now may become numbness afterwards. It may start tingling and become numbness or lack of sensation, or decreased sensation. But stroke doesn't do that. Stroke rarely starts with tingling. Rarely. Tingling is usually a migraine phenomenon, not a stroke phenomenon. And not only that, stroke symptoms that are sensory don't travel. They don't start in one part of the body and go somewhere else. They do in migraine. In migraine, the symptoms may start in the mouth, then go to the arm, the leg, or maybe start in the arm and then the leg, or maybe the leg to the arm to the mouth, etc. And usually over minutes to hours. That's typical of migraine, not of stroke. Not all migraine attacks are the same, even in the same individual. Most people have several different types of migraine attacks occurring at different times. These migraine types include migraine headache without aura, migraine headache with aura, migraine aura without headache, abdominal migraine with or without headache, often called irritable bowel syndrome by other doctors, and IBS or irritable bowel syndrome is actually abdominal migraine. Precordial migraine with or without headache. Precordial refers to the chest. This is patients with chest pain spells with normal heart tests, often misdiagnosed as panic attack, especially if there's an element of dysautonomia with it, with fast heartbeats and things like this. Sensory phobias, intolerance to light, sound, motion, smells, and or temperature are common in all the different migraine types, and triggers may be the same for all migraine types. During a migraine attack, what tests are abnormal? And the answer is usually none, and this is what confuses doctors the most. During migraine attacks, brain scans are normal. Heart evaluations are normal. Abdominal x-rays, CT scans, and scopes are all normal. However, during migraine attacks, the blood pressure, as I've said before, may be high or low. Not only that, but gallbladder and intestines may move more slowly than usual, making doctors think the primary problem is in the gallbladder and intestines when it isn't. If you keep having spells of headache, bellyache, chest pain, visual symptoms, tingling, etc., and all the tests are normal, think migraine. Patients who have migraine with aura may have what's called UBOs, or unidentified bright objects, on their MRI brain scan. These UBOs are chronic. They're there for a long time. They're unimportant, and they're little white spots of unknown cause, and they're benign. They do not require further evaluation or treatment. They're often mistaken for strokes or multiple sclerosis by doctors, but unlike those conditions, these white dots are small and round with fuzzy borders and located peripherally. That means more towards the outside of the brain, just underneath the brain's outer layer. They're not near the black spaces in the middle called ventricles. Both multiple sclerosis and stroke abnormalities are found more inside the brain, closer to the ventricles. This picture shows arrows pointing to multiple unidentified bright objects of migraine on an MRI scan of the brain. So this is likely the first time you're hearing much of this information. Why don't people know this? Well, first of all, patients and family members think they have something else besides migraine or rationalize their symptoms. Common Common refrains I hear from patients are, oh, I don't have migraine, I have regular headache, or mild headache, or tension headache, or sinus headaches. Or I just get frequent GI viruses or food poisonings. I have IBS or spastic colon. I have a nervous or sensitive stomach. These patients don't realize that actually all of their symptoms are due to migraine, both the headaches and the GI symptoms. Patients often don't know their family history either, because migraine symptoms are most prominent in early adulthood. Young adult patients no longer live with their parents or siblings and rarely discuss minor or transient ailments with their family members. And when the patient's parents were young adults and had migraine symptoms more prominently, the patient was too young to even realize what was going on and never knew his or her parents had migraine. One of the reasons why doctors don't know more about this brings up the story of the blind men and the elephant. This is a very old story from India, retold by the American poet John Godfrey Saxe in the 1800s. In this story, 6 blind men come upon an elephant. Each man feels a different part of the elephant and comes to a different conclusion regarding what he is feeling. One blind man feels the trunk and says, this is a snake. Another one feels the tusk and says, no, it's a spear. Another one feels the ear and says, no, it's a fan. Another blind man feels the leg and says, it's a tree. Another one feels the side of the elephant and says, no, it's a wall. And still another blind man feels the tail and says it's a rope. None of the men realize they're actually feeling an elephant. Like the story from ancient India, each specialist sees a different symptom of migraine and comes to a different conclusion regarding the diagnosis. Specialists tend to stay in their lanes, take only limited histories they feel are pertinent to their specialties, and choose from a limited list of possibilities. For example, ear, nose, and throat doctor, ENT, might see a patient and say, oh, it's a sinus infection, ear infection, allergy, or Meniere's disease. Certain neurologists might see a patient and say, oh, it's a tension headache. Cardiologists might say, well, this is POTS. I'll explain what POTS is later. Maybe a psychiatry doctor or even a cardiologist might see a patient and say, well, it's a panic attack. A GI doctor might see a patient and say it's IBS. And an OBGYN might see somebody and call it PMS. Well, none of the specialists realize the patient actually has migraine. The skeptics who hear my talks on migraine say, Gordon, you think everything's a migraine. That is not true and misunderstanding my message. Over the years, doctors have given names to many non-life-threatening symptom complexes that are actually consistent with migraine and respond to migraine therapies. In other words, a spell by any other name is still a migraine. Look at the list on this slide. Tension type headache, cervicogenic headache, that means a headache from the neck, a thing called nummular headache, regular ordinary headache, sinus headache, recurrent sinus congestion, bloody noses of unknown cause, red ear syndrome, motion sickness, irritable bowel syndrome, functional, meaning psychiatric related dyspepsia or heartburn, infantile colic, believe it or not, is migraine, recurrent vertigo, so-called Meniere's syndrome, atypical non-cardiac chest pain, pelvic or groin pain of unknown cause, premenstrual syndrome, also known as dysmenorrhea or PMS, morning sickness, hyperemesis gravidarum, that's the severe morning sickness, cannabis hyperemesis syndrome, where marijuana makes you vomit excessively, believe it or not, probably a migraine variant, panic attacks, anxiety, sometimes is migraine. I'm not saying these things are always migraine. That's what I'm saying. I'm saying if you have these things and tests are normal otherwise and you can't figure out a reason, it often is migraine. Palpitations of unknown cause, transient symptomatic hypertension. I already told you, hypertension is not symptomatic. In other words, it can't cause symptoms. But if you think you have symptomatic hypertension, it's migraine. Postural orthostatic tachycardia syndrome. That's the POTS thing I mentioned a moment ago, which is associated with fainting. And in general, fainting, or also known as syncope, same thing, of unknown cause. Commonly due to migraine, but not thought of as a possible cause. Cardiologists don't think of it. Transient global amnesia, a common phenomenon in old folks, people over 60, and always felt to be a mystery, but it's actually a migraine with amnesia aura. episodic confusion in any age, strokes or TIAs with constantly the same with normal MRIs, like I've described already, post-concussion headaches I've already told you, and hangovers. They're really all consistent with migraine and respond to migraine therapies. Please note that over half of these symptoms are actually just symptoms of dysautonomia, the autonomic nervous system affecting your blood pressure, pulse, and GI tract, right? The red underlined italic ones. Misdiagnosing migraine is a common phenomenon. The top 6 reasons to visit the emergency department in the United States per data in 2020 are abdominal pain, chest pain, shortness of breath, fever, cough, and headache. In one big study of emergency department patients, 31% of patients who presented with abdominal pain had normal tests and were diagnosed with so-called non-specific abdominal pain. In another study of patients with chest pain presenting to an emergency department, 58.7% had normal tests and a diagnosis of anxiety, panic, unknown cause. And still another study of patients who presented to the emergency department with headache, if the patient had a normal neurologic exam, CT scan was non-contributory 99% of the time. 67% of the time, the CT scan was normal, and 32% of the time it found something that didn't matter, an incidental finding. Although I have to tell you the biggest danger for me is the incidental finding, because perhaps the doctors mistakenly thought that was a problem and maybe even did something about it like surgery when it was inappropriate. So the question is, what percentage of patients who go to the emergency department with these various symptoms, abdominal pain, chest pain, and headache, actually have migraine headache or abdominal migraine or precordial chest pain migraine? I think a lot. So does it matter if we misdiagnose migraine? Well, there are some very serious, unfortunate consequences. First of all, patients who are misdiagnosed will undergo unnecessary, potentially expensive tests and potentially invasive tests. These tests may include CT, MRI, endoscopy, colonoscopy, and angiography. Patients who are misdiagnosed may take medications unnecessarily with potentially dangerous side effects, such as frequent antibiotics with resultant bacterial resistance, or decongestants, which actually, when taken chronically, lead to chronic nasal congestion, make things worse, and raise your blood pressure. Anxiety drugs or antidepressants with the social consequences of having a false diagnosis, being called anxious or depressed when you really aren't. Blood thinning drugs, which may cause dangerous bleeding if given inappropriately. And even narcotics, often given by doctors for chronic symptoms, who then misdiagnose the patient as drug seeking when they themselves prescribe the medicine. Misdiagnosing migraine may result in unnecessary surgeries, gallbladders taken out for no reason, pieces of colon taken out for no reason, the uterus, ovaries, sinus surgeries or ear surgeries for no reason, or even brain surgery for things like a Chiari-1 decompression, which is rarely necessary, and arachnoid cyst removal, which is just about never necessary. Mistakenly thinking those things found on an incidental finding on MRI, on a CT scan rather, is the cause of the headache. And then there's inaccurate psychiatric diagnoses, unnecessary disability, retirement, or divorce because the spouse cannot believe the patient must be faking it, and continued untreated symptoms affecting daily activities. If you are found to have migraine or are diagnosed appropriately, can we do something about it? The answer is 100% yes. There are 2 kinds of migraine treatment: stoppers and preventers. Stoppers are medicines that if you take as soon as possible at the start of a migraine attack, you can either stop the attack or make it less severe. Preventers are medicines that if you take on a regular basis are likely to give you less frequent and less severe migraine attacks. Let's talk about migraine stopper therapy. Here are the general principles. The earlier in the attack you take a migraine stopper, the more likely it will be effective. Some stoppers are non-specific medications that treat a migraine symptom, such as pain medicines. They're treating the pain of the migraine, not the rest. They're called analgesics or anti-nausea medicines. Some stoppers were developed specifically for migraine, but very importantly, some stoppers can actually make migraine worse if taken too frequently, typically more than 2 days per week. This is called medication overuse headache, and we'll talk more about this later. So among migraine stopper therapies, the most basic are pain medicines or analgesics. If you have infrequent headaches, these medications may be effective. But when taken more than 2 days per week, all of these medications can worsen your headache and other migraine symptoms through that phenomenon I just talked about, medication overuse. So these are the medicines we're talking about. Single drug pain medicines, single drug analgesics like aspirin, acetaminophen, brand name Tylenol, non-steroidal anti-inflammatory drugs or NSAIDs such as ibuprofen, which is Aleve or Motrin, naproxen sodium, opioids such as hydrocodone, oxycodone, Lortab, and Percocet. But I have to tell you, very importantly, opioids, also known as narcotics, are almost never necessary. Almost never. And other medicines will do the trick better, actually. Then there are combination analgesics, medicines, more than one pain medicine together. Excedrin migraine is a classic example. It's acetaminophen, which is Tylenol, aspirin, and caffeine together. Caffeine seems to make the other pain medicines work a little better. BC powder is actually the same exact combination, acetaminophen, aspirin, and caffeine. Goody's headache powder is aspirin and salicylamide and caffeine. Fiorinol is aspirin, butalbital, and caffeine. Fioricet and Esgic are acetaminophen, butalbital, and caffeine. And then there's Migraine, acetaminophen, dichloralphenazone, and isometheptine. All of these may work, but every single drug on this page can make things worse if taken too frequently. Triptans are medications that were designed specifically to be migraine stoppers. They can be very effective. But like the analgesics, when taken more than 2 days per week, triptans can worsen your headache and other migraine symptoms. Also, triptans are unsafe in some patients. The generic names of these drugs end in triptan. That's why they're called triptans. There's sumatriptan, elatriptan, zolmitriptan, naratriptan, sumatriptan combined with naproxen sodium, rizatriptan, almatriptan, and trovatriptan. These medicines specifically target the migraine brain receptor. They mimic serotonin at specific migraine areas in the brain, and they stop the entire migraine process, headache, nausea, etc. And they're safe in the vast majority of people, but rarely may cause arteries to spasm. So to be safe, we avoid triptans in elderly patients and very young children, patients with a history of stroke or heart attack, or patients with certain kinds of migraine. Gepants are newer medicines designed specifically as migraine stoppers. They can also be very effective, and they do not worsen migraine if taken too frequently, and are safe in most patients. The generic names for Gepants that work as migraine stoppers include Ubrogepant, which you may see as advertised Ubrelvy, Rimegepant advertised as Nurtec ODT. These medications specifically target the CGRP receptor. Remember, I talked about the CGRP chemical blocking pain receptors in the meninges that sac around the brain. And that's what this medicine does. It blocks CGRP from turning on those pain nerves. It also helps by blocking other CGRP receptors within the brain. Now, these medications can interact with other medications and may be affected by severe liver or kidney disease. Other migraine stopper medications for use at home include specifically an anti-migraine medicine, DHE45. Now, this drug has been around for a long time, in fact, 1945. That's how it got the name DHE45. Original migraine-specific drug way before triptans and Gepants. Currently, for home use, it's available via nasal spray. Antihistamines can be used to help nausea and help to sleep, such as hydroxyzine or promethazine. And then there's antidepressants that help to sleep, such as trazodone or doxepin. In severe migraine attacks that don't respond to medicines at home, there are drugs you can give in the vein, intravenously, IV, in the emergency department especially. And these include magnesium sulfate, prochlorperazine, metoclopramide, valproate, chlorpromazine, droperidol, DHE45 in the veins, and ketorolac. Now, a couple of points here. First of all, ketorolac is an NSAID, so actually it can worsen the headache syndrome if patients have medication overuse as an exacerbator. A common migraine cocktail, i.e. A combination of medicines given at one time in the emergency department to break a migraine attack, consists of 3 drugs together: magnesium sulfate, 1 gram, prochlorperazine, 10 milligrams, and diphenhydramine, 25 milligrams. Now, the diphenhydramine is actually given not for the migraine per se, but to guard against a possible side effect of the prochlorperazine. It also treats nausea and makes the patient a bit sleepy, since sleep helps migraine. It's the magnesium sulfate and the prochlorperazine that specifically can stop the migraine itself. Now, especially severe attacks may not respond to only 1 dose of these IV medications, and sometimes require repeat doses every 8 hours for as much as 3 to 5 days. Why might you have a daily headache that doesn't go away? Well, it may be your medicine's fault. And as I alluded to before, we call these medication overuse headaches. They used to be called analgesic rebound headaches, but we found out that analgesics are the only drugs that cause these. This phenomenon occurs when you take an analgesic pain medication, or triptan, or decongestant, or muscle relaxer, more than 2 days in a week for a prolonged period of time. The symptoms include daily headache, usually a dull ache that fluctuates in severity. It tends to be worse when you're withdrawing from the medications and better as soon after you take them. Constant migraine symptoms such as abdominal pain and tingling, not just headache. And ineffective migraine stopper and preventer medicines. Most migraine medicines don't work when you are in the midst of medication overuse. It's the most common reason for long-standing daily headaches, and is more common in patients who also have migraine. And it can happen even when the medication, for example, the analgesic, is taken for a non-headache situation, such as arthritis pain or knee injury pain or surgery pain. Now let's discuss migraine prevention therapy, and here are some general principles. First of all, CGRP inhibitors are the only agents developed specifically for migraine headache, and I emphasize headache. They weren't designed for non-headache symptoms, although they do work for many of the non-headache symptoms. Different CGRP inhibitors are given in different ways. Some are given in injection under the skin, some are given in the veins, and others by mouth. All other migraine prevention medicines were first developed for some other condition, and we later found out they also prevent migraine. We choose these migraine prevention medicines based on what side effects will be good for you. For example, some of these medicines are blood pressure medicines, so they lower blood pressure. Some might help you lose weight. Some might help insomnia. Some can help with stool consistency. And some treat depression. And some are good for arthritis or seizures. Different people respond differently to different drugs. Your provider cannot predict which will be the right drug or drugs for you all the time. Many people, in fact, need more than one migraine prevention medicine for optimal control of their migraine condition. Let's look more in depth at migraine prevention therapy, specifically the speed of efficacy, dosing, and overuse. So CGRP inhibitors for migraine prevention take effect within days after the first dose in most cases. They do not require dose adjustments in most cases and are effective even during medication overuse. All other migraine prevention medicines should start low and go slow to avoid unwanted side effects. Start a low dose, increase dose gradually every 2 to 4 weeks. And they take at least 4 weeks for full effect. Every time you add a new medicine or change the medication dose, so the patient must be patient. These other migraine prevention medicines, the non-CGRP ones, should only be stopped if an unwanted side effect occurs. You should not stop them if your only concern is lack of effectiveness. since it may be a higher dose would be effective. Just tell your doctor or provider, and maybe they need to increase the dose. And these medications are not effective during medication overuse. So again, note, CGRP inhibitors do work even in medication overuse, but the other migraine prevention medicines do not. When is it necessary to take a migraine prevention medication? Well, if migraine symptoms occur at least 2 days a week, or if migraine symptoms are debilitating, they interfere with activities of daily living despite taking a migraine stopper medicine. In most cases, it is sufficient to provide your doctor with a general estimate of migraine frequency, but if you have great difficulty recalling the frequency, you can keep a calendar or diary either on paper or on a phone app. If you begin a migraine prevention medicine, do you have to take it forever? Or when can you stop it? Well, you might consider discontinuing migraine prevention therapy if both the migraine frequency is rare and the medication is not needed for something else, some other condition, such as high blood pressure or depression. Note, however, that sometimes a migraine prevention medicine is not as effective after stopping it and restarting it. So one should be careful about stopping migraine prevention therapy. These are the categories of migraine prevention therapy. The most effective prescription drug categories are CGRP inhibitors, certain blood pressure medicines, certain seizure medicines, and certain depression medicines or antidepressants. It's not all medicines in the blood pressure, seizure, and depression category. It's some of them. And a person may respond to a drug in a certain category even after not responding to another drug in the same category for all 4 of these categories. NSAIDs, non-steroidal anti-inflammatory drugs, well, only prescription naproxen, only that drug is an NSAID effective for preventing migraines. Over-the-counter naproxen versions, such as naproxen sodium, which is a leave-in anaprox, do not work for migraine prevention. They may work for migraine stopping, but not prevention. There are other over-the-counter medications that work for migraine prevention, such as magnesium, coenzyme Q10, melatonin, and riboflavin, which is also known as vitamin B2. They can prevent migraine. And Botox, you may have heard of, botulinum toxin type A, is good for migraine prevention, but it's only indicated if migraine headaches occur at least 15 days per month and are unresponsive to other medications. So most people will not qualify for Botox for migraine prevention. Here is a list of the top medication choices by category. Among the CGRP inhibitors, we have Erenumab or Aimovig subcutaneously, that's under the skin. Fremanezumab or Ajovy, also given subcutaneously or an injection under the skin. Galcanezumab or Emgality, given via subcutaneous injection under the skin. Eptinezumab or Vyepti is given by the veins. It's given every 3 months. The other 3 subcutaneous drugs are given every 4 weeks, and eptinezumab is given every 3 months, but in a vein in an infusion center. Then there are oral medications that work for migraine preventions. We mentioned earlier that Rimegepant or Nurtec ODT works as a stopper. It also works as a preventer. And then Atogepant or Qulipta is another oral CGRP inhibitor, a Gepant, that works for migraine prevention. Certain blood pressure medicines, when taken regularly, can also prevent migraine. The most healthy one that's now used very frequently is Candesartan. Nadolol is a good one, and atenolol is a good one. And the other ones on the list also are effective for migraine prevention. But I think Candesartan, Nadolol, and atenolol on this list are probably the best ones. Among the seizure medicines that also work for migraine prevention, topiramate and divalproex are by far the best. For some reason, a lot of doctors like to use gabapentin, but it tends to work less well for migraine. It's good for general other pain, neuropathic pain, but not necessarily migraine. The only more modern antidepressant, it's called an SNRI antidepressant, that works for migraine prevention is venlafaxine. It can work quite well. Old school tricyclic antidepressants, such as nortriptyline and amitriptyline, can be effective for migraine, but they have side effects such as lethargy, weight gain, and dry mouth. So in general, I think this list is a good one for a place to start for migraine prevention medicine, and my preferred agents are bold in red. Coming back to botulinum toxin type A, or Botox. This drug is indicated if you have chronic migraine, not responding to medications, and not due to medication overuse. You have to have a headache for at least 15 days per month for at least 3 months. You have to have migraine features for at least 8 days of those months. And no response to at least 3 migraine prevention medicines. The dose is 155 units divided into 31 sites around the head, given by intramuscular injections every 12 weeks. We're not sure how it works, actually, but it can be very effective. It's not a first-line therapy, but like all migraine therapies, it can be effective for some patients. What if you have medication overuse syndrome? In other words, you're taking medicine on a regular basis that's making all your migraine symptoms worse and not responsive to a lot of medicines. Well, this is how you treat it. First of all, be prepared. Pain and other symptoms may increase as you withdraw from the offending agent. Also, however, be hopeful. The daily symptoms will resolve after the withdrawal period. And be aware, intermittent migraine attacks return after the withdrawal period. Be prepared, be hopeful, and be aware. So our first step is to discontinue the offending agents. Discontinue all these agents until daily symptoms resolve. Usually the range is anywhere from 3 days to 7 months, believe it or not. Triptans, which are migraine-specific drugs, are the worst offenders. Their withdrawal may take up to 6 to 7 months. Over-the-counter analgesics tend to take only 3 to 10 days on average, and prescription analgesics can take a little longer. But please remember that prescription naproxen does not cause this phenomenon. And by the way, diclofenac, potassium, and meloxicam also don't cause this phenomenon. You should permanently discontinue some agents, such as ondansetron, which is given for nausea, but if the nausea is due to migraine, it actually can make it worse. Ondansetron can worsen migraine. Dipyridamole, given for blood thinning, can worsen migraine. Muscle relaxants, decongestants, vitamin A, energy drinks, artificial sweeteners, and yes, CBD can all make migraine worse through medication overuse syndrome. And consider stopping a proton pump inhibitor. Those are those medicines given for ulcers or reflux that end in zole, like omeprazole or pantoprazole. Sometimes they worsen migraine also. If you have medication overuse syndrome, one option is to take CGRP inhibitor. These medications have proven efficacy for medication overuse syndrome. They're effective within days. There are no dose adjustments necessary and generally do not require additional sedation during withdrawal. If you are unable to take a CGRP inhibitor, then you can take a sedating medication during the withdrawal period, especially the first 3 to 10 days. Take prescription enteric-coated naproxen, that's otherwise known as naproxen DR, delayed release is what DR stands for, on a regular basis, around the clock, twice a day, and while you're withdrawing. And begin a non-CGRP migraine prevention medication, which take about 2 to 4 weeks to become effective, and require increases as necessary every 2 to 4 weeks. Of course, you must prevent future medication overuse. After daily symptoms resolve, limit the total use of triptans and analgesics, other than prescription naproxen, to 2 days a week at most to prevent recurrence. This is the end of this presentation. A DLG Insight production. Innovative neuroscience ideas and thoughts on education. I am DLG, David Lee Gordon, MD.